morning. My name is Beatriz Soler. I'm the head of Secretariat of the European Students' Union, which is an entity part of this European project Train for Health. Welcome to this second webinar organized in the framework of the European project Train for Health on advancing self-care support for people with chronic disease. It's really a pleasure to see how many participants we have in this second webinar we organized. So really thank you for being here, and we really hope that you will learn a lot from this webinar, and you can improve better your understanding about self-care and in chronic disease. Well, this event is part of the Learning, Teaching and Training Activities program within the project through 2020. And before starting, we would like to show you some slides about what is this Train for Health project, who are the entities that make up the consortium, and what is the main objective of it. It will take only 1 minute, and then we will move to the technical content of the webinar. My colleague Maria is sharing the screen for you, so you can find here about this project. This project is funded by the European Commission through the National Agency in Portugal. And the complete title of the project is Improving Healthcare Students. Sorry, Maria, the first one. The Healthcare Students' Competencies for Behavior to Effectively Support Self-Care in Chronic Diseases. This is the website of the project, trainforhealth.eu. And these are the social media that we are using, a Twitter, a Facebook group, and also Instagram. And for sure, we invite you to check not only our website, but also our social media, and share and post some information on these tools. Well, the consortium is including many different countries. It's Portugal, it's Brussels, Ireland, Netherlands, and Slovenia. So this is the entities that we are part in this Train for Health consortium. The duration of the project is 36 months, and we started with this project last year, in autumn last year. This is the project reference. And some general words about the main objectives of this project is to consolidate a European multidisciplinary competency framework on behavior change supporting chronic disease. Also defining learning outcomes basic curricula informed by the competency framework previously developed. Also providing test case studies for training behavior support in chronic disease. Provided also a test e-learning course as a MOOC. Delivering a test simulation software. And producing, after all these tools, producing some recommendations to be implemented in the Train for Health educational package. Our main audience of the projects are mainly the target audience are students, higher education institutions, general society, and for sure people with the chronic disease. And I will stop here. I invite you please to contact us in case you have some questions, or in case you want to receive some information from us, some information about the project. And please visit our website and our social media, and you can find all the information related to this project in terms of consortium, objectives, and the activities. So before I start, once the context of this event has been explained, let's move on the technical content of the webinar. For today's session, we have 3 experts in different disciplines who will talk to us about self-care support for people with chronic disease from different perspectives. With these 3 interventions, we will get a better understanding of the contribution of behavior change science to self-care in chronic diseases, the contribution of the pharmacy profession at a global level, the contribution of interprofessional work to advance self-care, how can nursing, pharmacy, and sports science students become more engaged in behavioral change support to facilitate self-care in chronic disease. The way of doing this webinar is after each speaker, after each intervention, we will open the floor for some questions. And for sure, after the 3 interventions, after the 3 speakers, we will open again the floor for your questions. How share with us your questions? You can do it through different ways. You can use our chat, please. So in the chat, you can write directly the question, or also you can drop a star and ask the question in a verbal way. And also in the participant list, you can also raise your hand and we will give you the floor and you can ask all questions you consider to our three speakers. Please, in order for a better and clear understanding, I really ask you to mute your microphones and open it when you have some questions or some suggestion or recommendation or something to be shared with all of us. So first we will start, let's move with our speakers. First we will start with Dr. Maria Brien. She's the National Project Manager, Making Every Contact Count program in Ireland. Maria, really thank you very much for being here today, and please, the floor is yours.
So, as I said, my name is Maria O'Brien and I'm the National Project Manager for a programme here in Ireland called the Making Every Contact Count programme. And the programme basically is a programme that we're implementing across the National Irish Health Service, where we're trying to ensure that every time a patient comes in contact with a healthcare professional, that they're, I suppose, asked about their lifestyle behaviour and that they receive an intervention, a brief intervention around trying to change that behaviour. And that's something that we've been working on for the last 4 or 5 years here in Ireland, trying to implement this across the Irish Health Service. And part of that has been around looking at the long-term sustainability of training our healthcare professionals into the future and how we actually do that and engage with our higher education institutions to do that. So that's what I want to talk to you a little bit about today, is the process of what we've been the work we've been engaged in and what we've actually progressed in terms of doing that piece of work. But I suppose just before I launch into the piece around the higher education institutions, I want to give you a context for the program as such. So as I said, it's the Making Every Contact Count program. We're trying to implement a framework for behaviour change across the entire health service for all healthcare professionals. So that's nursing, medical staff, dental staff, and all allied healthcare professionals. So it's a very broad range of healthcare professionals. And the key objective of the Making Every Contact Count program is chronic disease prevention and management, that interventions on lifestyle become a routine part of all clinical care, and that healthcare professionals are aware of and understand their role and the opportunities that they have every day to help people make lifestyle behaviour changes for the prevention of chronic disease, but also for the self-management of existing chronic diseases. And we focus primarily on the main lifestyle topics of alcohol, smoking, physical activity and healthy eating. So that's the programme or the context within which I've been working over the last 4 or 5 years. We have a model for making every contact count for behaviour change, and the reason I want to show you this is, I suppose, to show that there are different levels of competencies required depending on the level of intervention that you as a healthcare professional are going to deliver to your patient. So a very simple intervention around grief advice might not require so much of the competencies in terms of, reflective listening, summarizing, and all of those, really intricate behavior change competencies, which are really important to support people and move them along the continuum of change. Brief intervention is where we have pitched our current level of training for healthcare professionals at, and also in terms of that's the level of competence that we're currently trying to create right across the health service with our 80,000 healthcare professionals. Extended brief intervention is a little bit more intensive and requires, I suppose, further competency development again, and isn't something that we've actually progressed to at this point. And we've included specialist services there that would include dietitians or alcohol support services, where people would be providing counselling services essentially to support behaviour change. So the focus of the Making Every Contact Count programme to date has been around building the competence within our own existing healthcare professionals to the level of brief interventions. And how we have done that and achieved that is through development of a national training programme, which I'll just describe to you a little bit now. And the importance of this programme, you'll understand why later in the presentation. So I suppose just in terms of looking at competencies for training healthcare professionals, there was a piece of work which I've been involved in back in 2015, which had looked at identifying what were the kind of standard competencies that healthcare professionals in Ireland were required to be able to deliver a brief intervention. And we, I suppose, identified 5 different standards around knowledge and the policy context of the behaviour change, the theoretical context of brief interventions and health behaviour change, the actual approach, the practical approach of doing a brief intervention, which included assessment and screening, being able to signpost and refer patients to services, and knowledge of the specific health behaviours. So whether it was alcohol, physical activity, healthy eating, that you had a core knowledge around that. Now that national framework was developed, and unfortunately it's unpublished, but I can, I suppose, provide it to anybody who might want it. But I suppose why I wanted to show this to you today is that these were the standards which were used and informed the development of our national training programme for making every contact count and brief interventions for behaviour. Okay. So this slide just outlines, I suppose, briefly the content of our training programme. The training programme which we have available for our existing healthcare professionals is made up of a number of e-learning modules, and having completed the e-learning modules, all of our staff are then can progress to do a skills, face-to-face skills development practice workshop. So I've just given you an outline of, I suppose, what the context or the construct of that training program looks like, but I'm also giving you the link to where you can actually access the e-learning training program if any of you are interested to go and have a look and see in relation to the content or the makeup of that any further. But I suppose the core piece is that there's a core knowledge that we give to people in terms of introducing the concepts of behaviour change and how to actually do that. Then we focus on the 4 kind of key topics, but within each of those topics, we, I suppose, focus in as well on how to actually deliver a brief intervention specific to each of those lifestyle topics. And the last module there, skills into practice, is very much demonstrating the skills into practice through a range of vignettes which we actually filmed ourselves with patients and real healthcare professionals to demonstrate good practice in terms of delivering brief interventions in clinical practice. So that's a really good module there. And then the skills workshop is a 3.5 hour face-to-face workshop, which is challenging in the current environment. So we're having to look at alternative methods of delivering that classroom-based workshop, and we're still in the process of that just due to the COVID environment. So that's the existing training program that we have for our healthcare professional staff. And the reason I wanted to, I suppose, outline that to you is that while we're rolling that out across the healthcare, around the health services to all of our healthcare professionals, we've also started a piece of work working with all of our higher education institutions to try and catch our healthcare professionals at the earliest point in their education. And we've taken this training program and integrated it into the majority of undergraduate healthcare professional training programs across all of our universities and institutions in Ireland. And I want to talk to you a little bit about that. Just I suppose in terms of the skills workshop that we do deliver for our own staff, the workshop is delivered in a classroom environment, but it is delivered to multidisciplinary groups of healthcare professionals. So it wouldn't just be a group of physios or a group of nurses, it would be delivered to a multidisciplinary group to support that interprofessional education and learning, and to support implementation of the programme across services as well, in terms of taking that joined up approach. So this is one of the projects, I suppose, that I wanted to talk to you about under the umbrella of making every contact count. While we knew we had a really big job to do and still have a big job to do in training our existing healthcare professionals to be competent and confident in delivering brief interventions and behaviour change initiatives, we wanted to look to the long-term sustainability of it and how we would actually embed this at the earliest point in education of our healthcare professionals that we could. So what actually happened was that there was a national collaboration across all of our higher education institutions was set up, which is the first time to my knowledge that something like this has happened in Ireland, and that was set up, I suppose, initially in September 2015, but the work of the group actually started in kind of 2016. And I suppose the purpose of this collaborative group coming together, which had representatives from all of the different higher education institutions and had involvement from ourselves in the HSE, and I would have sat on these collaborative groups for the last number of years, was to look at the undergraduate curriculum for health professionals in Ireland, and to look at, I suppose, chronic disease prevention and management, and what could we do to embed this in undergraduate learning at the earliest point. So we actually broke it into two components. The first piece was looking at chronic disease prevention and management from a behaviour change perspective. And that was the first piece of work that we worked with. So we worked with the national steering group, but particularly with the national working group, was established and met once a month from 2016 up until just, I suppose, probably June this year, to develop the content of the curriculum in a collaborative way. And also what happened was, within each of the institutions, while they were represented around the table at that national working group on a monthly basis, each of the institutions set up their own local working group, so that there was a complete involvement and collaboration across each of the different institutions, whether it be across departments of medicine, nursing, and all and the other allied healthcare professional departments that were in existence as well. And so we developed this undergraduate curriculum, which is available to download free on the link, as you can see, www.hse.ie. It's an interactive PDF document, and it's been distributed across all of the institutions, and it's being implemented across all of the universities and institutions in Ireland since September 2017 in a huge range of undergraduate programs. I won't say that it's completely embedded and completely happening in every institution, in every department, but there's significant implementation happening at this point in time, and we're continuing to work with the institutions to try and, I suppose, increase that spread. So just to give you a sense of what the curriculum actually looked like, it's broken into 4 units, and each of the units has a specific focus. Unit 1 looks at health and personal wellness, and the aim of that is to be delivered very early, maybe in year 1 of undergraduate programs. Unit 2 looks at lifestyle behaviours and personal responsibility for health, and explores students' own understanding of their own health and their understanding and beliefs around health and health behaviour. And again, that's a unit that we would, I suppose, anticipate would be delivered fairly early in undergraduate programs. Unit 3 is around communicating for healthy lifestyles and health behaviour change, and I suppose this is the foundation where we look at models of behaviour change and look at the theory and the concepts of behaviour change, so that, I suppose, students have a strong grounding from a theoretical perspective. But also in Unit 3, what we've actually made happen is the training program, which I explained to you earlier in the presentation, is embedded as part of that Unit 3. So when students are now being delivered this curriculum, they now train and complete the HSE Making Every Contact Count training program as part of their undergraduate training. And then Unit 4 is, I suppose, bringing it all together, and it's the skills practice element. So we would have trained and upskilled a lot of the university and institutional staff to deliver skills practice workshops around lifestyle behaviour change, and students would get an opportunity to do one of those workshops in Unit 4. And again, I suppose it's a spiral curriculum that builds through the different programs. It's 20 hours in duration, but it's up to each program to implement across their program where they feel that it most appropriately fits. And I suppose the parallel kind of horizontal strands of person-centred care and health promotion for chronic disease underpin each of the different units. So that's basically the construction of the curriculum and what it looks like. And this is the competency framework, which I suppose was one of the key exercises that we did, having mapped what was already happening in existing curriculum in relation to behaviour change, identifying what were the core competencies that needed to be developed and embedded within the curriculum. This was then the competency framework, which was used to build Unit 1, 2, 3 and 4. And you can see it outlined there, and I won't go into the detail of it, but we can talk about it more in a while if you would like to. In terms of implementing the curriculum across the different institutions, one of the key things we were very keen on was interprofessional learning for the students and the opportunity for interprofessional learning across the institutions. So the skills practice workshops that are delivered in Unit 4, there is an opportunity there for interprofessional learning across the different undergraduate programs in each institution. And I suppose one or two of the institutions have delivered those skills workshops in a multidisciplinary way, where they've maybe medicine have joined up with nursing, or medicine have joined up with the physiotherapy department to deliver the program and to deliver the skills workshops in a multidisciplinary way. So that's actually been very, very valuable. So that's the behaviour change, making every contact count, part 1 of the curriculum. I mentioned earlier that we actually had the curriculum in 2 parts, and the second part is an undergraduate curriculum on self-management support for chronic conditions, which has only been launched earlier this year. So implementation isn't as embedded or progressed for this particular curriculum as, say, the Making Every Contact Count, but the Making Every Contact Count certainly is a foundation stone to this particular curriculum, and we'll be continuing to work across the institutions to support them to implement the self-management support for chronic conditions curriculum into the next couple of years. And again, that's free to download on the link that's available there for anybody to look at. And again, there are teaching tools. We developed a suite of teaching tools for anybody who's involved in education and delivering some of these curriculum to support them in terms of delivering the content and integrating the curriculum into their programs. So again, we did a similar exercise with the self-management support curriculum, where we mapped what was already happening in terms of self-management support education across the range of programs in the different institutions, identified examples of good practice that we could use and take and integrate across all of the different institutions in Ireland. And then there were some new competencies which were actually, I suppose, judged to be missing or not currently being taught in the curriculum. So I suppose that all came together to form the competency framework, which was again used as the basis for then creating the content for the self-management support curriculum, which was just launched earlier this year. And again, there's a lot of detail there, so I leave that for people to read. And those competency frameworks are in both of those documents that I've highlighted as well. So if you download them, you can learn a little bit more about those competency frameworks and how we came to agreement on them through the collaboration across the different institutions. So I suppose in summary, and that's just the whistle-stop tour of some of the work we've been involved in, the key role of the Making Every Contact Count programme is to improve clinical practice and client-centred care for all of our patients. A key part of that has been around training our staff and building the competence to allow staff to be able to engage and talk about lifestyle behaviour change and deliver effective interventions to patients on a daily basis with all of their clients. One of the other pieces that I'll just mention that we've started working on is both for our existing healthcare professionals and for the healthcare professionals of the future, which are those that receive our curriculum. We've been engaging with our healthcare professional bodies who actually set the national standards for competence to practice for all healthcare professionals in Ireland, to try and embed some of the competencies that we've identified through these curriculum and through our own training programme into those standards for competence, so that it becomes a long-term sustained piece within the training and competence and delivery of services within Ireland for all of our healthcare professionals. And I suppose I just wanted to flag again, it isn't just for medical or nursing. This curriculum and our training programme, our Making Every Contact Count programme, is something that's being implemented right across the health service with the engagement from all disciplines of healthcare professionals right across the board.
Thank you very much, Maria, for this really, really interesting presentation. it's really a pleasure to learn from you. And also I saw a lot of connections with our project, so I hope we will have some really interesting questions to you. So now I will open the floor for questions to our speaker. We can, as I said before, you can use the chat or raise your hand in the participants as you will decide. And here, Maria, I think you can see in the chat, there is a question from Maria Sierra from ESU. Thank you, Maria, for your intervention. Did you have any obstacles or challenge while involving healthcare professional staff in the training program? And also, have you seen a concrete impact after 5 years of program implementation?
Okay, so first of all, the question around barriers to implementation is that in our own health services, obviously trying to get staff to buy in and trying to get managers to buy in to release staff to attend the training is always a barrier, because healthcare professionals' time is critical. So that's always been a challenge. But I think one of the things that worked really well for us was once people started to engage with the training program and started to talk about it, the good news in relation to the program spread quite quickly. So we had, very good buy-in from that perspective. Just the second question, or part of the question, was around, have we seen any impacts 5 years in? I suppose the training program with our own staff is only live 2 years, because the program has been working for 4 or 5 years. But I suppose it takes a lot of time to develop all of these products and all of these trainings. So the training program itself is live for the last 2 years as such. And we have started to see implementation of making every contact count and brief interventions into clinical practice across our health services, and we have some really good examples of that. But we're working very closely with a large number of sites across the HSE at the moment, to try and, I suppose, capture some of the lessons learned there and support people going forward, because this is to be implemented across all services in Ireland, across the health services. So it's quite a big, there's a bit done and a lot to do yet.
Great, thank you for the answer. We have a couple of questions. We have a question from Katja from the Netherlands, from In Holland University. What test tools did you use to assess what the students have learned from the curricula?
So we didn't set specific assessment tools. We recommended some assessment tools in terms of the curriculum, and very much, I suppose, this curriculum has been a collaborative piece. So what we've asked different institutions to do is to develop their own assessment methods. So some of the earlier Unit 1 and Unit 2 curriculum assessment has been integrated into examinations and assessments through questions. So that's a simple piece.
Please, I would like to ask, please, the rest of participants, could you please mute your microphone when the speaker is speaking?
So in terms of the Unit 3, which is when students get to do our own e-learning, the HSE, the Health Services e-learning training program, we had an assessment that we ask our own staff to complete. So that's been integrated into undergraduate curriculum assessment processes as well. The part that's been difficult to assess is the skills practice development and the competence, having completed the skills workshop. So we have a number of examples, and I suppose these skills workshops are starting to be implemented more across the institutions this year, because it's been a little bit slower to get that off the ground. So some of them have used simulated patient assessments, where they've set up a room with a number of different patients, and where students would then have to go and actually perform a brief and deliver a brief intervention, and would be assessed and observed on that and marked on that by their peers, but also by their teaching staff that were there. So that's how the assessment has worked. But we have very much, because this has been a collaborative piece, we haven't directed how the assessment should happen. We've, I suppose, allowed the experts in each institution and each programme to develop those assessment methods and to share those then across the institutions.
Okay, great. And we have I think it's the last question from you, from Mara, from our project coordinator. She said, brilliant project, which for sure we absolutely agree with her, about involving higher education institutions. What is bottom up? And how did you secure such a wide buy-in?
So, okay, it is something that hasn't happened before in Ireland. So I suppose, how we actually secured the buy-in initially was that in our health services, there's a huge reform piece happening, moving towards chronic disease prevention and management, keeping people away from acute services and keeping people as well as we can in the communities in which they live, work and play for as long as we can. And that's a huge strategic decision and move and commitment that's been made by our government and by our health services in terms of how we deliver our services. And I suppose how we initially got buy-in from each of the different institutions was that we actually invited a very high level person from each of the institutions to an initial meeting with some of the senior management of the HSC to say, this is actually what we're trying to do within our health services, and this is the role that we feel ye have to play in doing that, and we'd really like to set up this collaborative piece of work. Will you engage with us on it? And we actually got huge commitment even from that particular meeting. The next step, I suppose, that happened was that we had to depend on those people to go back and talk to their colleagues at a local level and to get buy-in at a local level. So that was kind of the initial buy-in. I think how we maintained buy-in was that we from the health services provided some supports. We provided a project manager to work with the institutions to actually develop the products and develop the content. And we met on a monthly basis. We supported those meetings in a very collaborative way. And I suppose one of the other things that helped with the buy-in is the setting up of a local working group in each institution. So each university set up their own local working group. And there was, I suppose, the national project manager, who wasn't me. I oversaw this project, but we had employed somebody to do that. We actually went on site around the country to each of the universities twice a year to meet with their local working group to maintain and create that buy-in as much as we could. So I think that's how we actually created that buy-in, through that. It is intensive collaboration and engagement with universities, but at different levels. So engagement on the ground with the people who are going to be delivering the content, engagement at a senior level within each of the institutions to maintain the agreement and buy-in to integrating the curriculum, and maintaining a resource to support them to do it.
Okay, great. Thank you, really, thank you very much for all your explanations, for your answers. I don't see any other question. So once again, really many thanks, Maria, for your really interesting presentation. It has been a pleasure to have you here and to learn from your project. So great, thanks a lot.
Thank you for having me.
And now let's move on to our next speaker. Welcome, Marta Marquez. She's a Marie Curie Research Fellow, Adapt Center and Trinity Practice Healthcare Innovation at Trinity College in Dublin, and also Research Fellow and Associate at Center for Behavior Change in University College London in UK. Marta, the floor is yours. You can share your screen with us, please.
Thank you, Beatrice. Hi, everyone. Can you see my screen?
Yes, perfectly.
As a full presentation?
Yes.
Yeah. If you have any problems also hearing me, just let me know.
For now, it's perfect. So we can see your slides and we can hear you perfectly.
Great, thank you. So thank you also for the invitation. It's really a pleasure to be here today. I'm gonna talk about how behavior change and behavioral science can contribute to improving the way we provide self-care support for people with chronic diseases. Because this is a short presentation, I will not get into a lot of detail in terms of examples of programs where we have applied the science that I'll be speaking about, but the idea is to give you an overall view of what we have been doing in terms of developing methods and frameworks and tools to support the work of researchers and healthcare professionals trying to develop this type of interventions. So I think the initial thing I would like to say, and Maria presented before me, and I think Maria did a really good job in explaining how behavioral change is key in this kind of programs, but I just wanted to emphasize that when we talk about self-care, when we talk about management of chronic disease, we're talking about behavior change and sustained health behavioral changes as an integrative key aspect to any type of intervention. And what we know from research, and in the last 20, 30 years, there have been a lot of research on this field. And what we know is that there's still a lot of variability in the effects of interventions that we have to change health behaviors. And there are lots of reasons why we have this variability. In terms of reporting, the way that we report interventions, the way that we develop them. But the fact that some interventions work really well, others don't work at all, and we find all of this heterogeneity means that we need to understand what are the reasons that are beyond interventions that are effective or not effective or with large and small effects. And how can we learn from this to improve the way that we design behavior change interventions, and as a result, how we train healthcare professionals and students to implement this type of interventions. And also a key aspect from our work is how can we use this knowledge to provide evidence-based guidelines for interventions on behavior change. And the NICE guidelines in the UK, for example, are a really good illustration of how behavior change science has been included in the guidance that they provide for healthcare. So when we say we need to understand how to design effective interventions, we're talking about understanding why they vary across different behaviors, physical activity, diet, medication, treatment, why they vary across populations and contexts, and why are they effective? So what are the mechanisms of action or the determinants that are responsible for their effectiveness? Are we talking about more social aspects, individual aspects, psychological aspects? Are we talking about all of them? We need to understand how the effects operate. And we also need to understand which components are effective. We were talking about using programs such as making every contact count to be implemented in healthcare services. This requires understanding which components of this kind of programs actually works so that we have the most cost-effective programs in the future that can be integrated in healthcare. So we need to understand which techniques, which content, which modes of delivery are more effective. And this is highly complex given the nature of human behaviors, but we're trying to make an effort to move in that direction. And one way to be able not only to understand this, but to improve the way that we design interventions and that we provide health behavior change implementations is to use systematic methods from behavioral science. And a lot has been developed recently. A lot of the work that I'm going to talk about has been developed in the Center for Behavior Change at UCL, but there are many, many other examples. We don't have time to go through all of them, but if you are interested in knowing more about those resources, I'm happy to share them. So just very briefly, when we're talking about the behavior change process, we are talking about a process that starts by identifying what are the health outcomes we want to influence, what are the health behaviors that need to change to have an impact on those health outcomes. So for example, if we're talking about losing weight, a key behavior is changing your diet. What are the sources of that behavior? So what needs to change for that behavior to occur? Are we talking about self-efficacy elements? Are we talking about social support? Are we talking about changes in food, in cafeterias, in schools, for example? And once we identify this pathway, so the behavior, the specific behavior we're targeting, the source, we can then select the techniques or the content that we are going to implement in this intervention. And we know that interventions are more effective if they target the sources and the behaviors that they are supposed to target. And using a behavioral science approach, this means that we use theoretical approaches to help with our thinking, to help with our design, and to help in understanding what is happening. So there are three core elements. The first one is the use of frameworks and theory to guide the development, implementation, and evaluation of interventions. And the behavior change wheel that I'm going to briefly describe is one of the most widely known examples at the moment of this kind of frameworks that we have been developing. The other aspect is trying to use a standardized language to describe and organize the components of behavior change interventions. So use a language and use well-defined entities, definitions, illustrations that everyone can understand and can refer to when reporting, when developing and implementing interventions. An example is the behavior change techniques taxonomy that I will briefly describe also. And the last aspect, and Marie also talked about this, and this is a core thing that in the Train for Health project, is developing frameworks that support in describing the competencies that are required to deliver those behavior change interventions. So what do healthcare professionals and students need to learn to be able to implement health behavior change interventions? So going to the first point about the frameworks that can guide development, implementation, and evaluation of interventions, the behavior change wheel is an example of such a framework. And it is a framework that has been widely used, and there's a lot of ongoing research looking at its effects and mapping the behavior change wheel to ongoing programs. Maria actually attended one of the trainings about the behavior change wheel, where we were talking about how can we map the behavior change wheel to existing programs to see what do programs adhere to and how can we improve them based on elements that might be missing from these frameworks. And the behavior change wheel as a key element, which is the fact that it was designed to be used by researchers and practitioners that are not psychologists. So that are outside from the health psychology field, which is my field. And this makes it much more easier to use in terms of the language and in terms of the scheme so that anyone can understand and implement it. The behavior change wheel is an integrative framework, so it results from a systematic review looking at existing frameworks and identifying for the purpose of behavior change, what is missing in those frameworks, how can we improve that, and how can we build something that can be of use. So in terms of the steps that I forgot to mention that the behavior change wheel has these three layers. So the outside layer is the policy categories. What do we need in a more macro level to implement to be able to support this behavior change interventions in different contexts? The layer in the middle, so the red one, relates to the intervention function. So what do we need to do in our interventions to change behavior? And we can use methods such as education or persuasion or training. And in the hub of the wheel, it's the model that describes the sources of behaviors, and I will describe that in a few minutes. So in terms of steps, the way that the behavior change wheel is designed is to guide on which steps we need to go through when we are developing or implementing any kind of health behavior change interventions and counseling. And in step one, the idea is to define the problem in behavioral terms. And this is a really important step because in a lot of cases, we start by thinking of our intervention approaches just by saying we need to improve physical activity or we need to improve self-management in chronic disease, but we don't define the specific behaviors. Are we talking about physical activity only? And if yes, what we want to improve or what we want to change in terms of physical activity? Are we talking about maintaining, increasing, reducing? It doesn't matter. Are we talking about a specific physical activity? We need to define in terms of behaviors, who needs to change the behaviors, what kind of behaviors need to change, and specifically what we want to improve. And this is the starting point to then start to select what we are going to include in our interventions. If we don't specify which behaviors we're targeting, we are going to develop interventions that are too vague and can apply to any type of behavior, but without targeting the specific determinants of those behaviors. So once we have this defined, are we targeting 1, 2, 3 behaviors and specifically what we want to change in those behaviors? then we need to think of what will take to bring about change. And fortunately, we have evidence to help us in making these decisions. And there is a model from the behavior change wheel called the COMBI model, which is a very simple model trying to identify those determinants that I will describe. Once we identify those determinants, then we need to think of what interventions will work. So what do we need to include? Which components? What content? Are we talking about a motivational intervention? Are we talking about a multi-level intervention? Are we talking about providing techniques of planning and self-monitoring? What are the kind of content we need to include to change those behaviors once we identify what are the sources and determinants of those behaviors? So when we think about the sources, we go to this green part of the behavior change wheel, and this is a very simple integrative model to think about the sources of behaviors. So the COMBI model says that any behavior is influenced by elements of capability, so the physical and the psychological capability that I have to perform a given behavior, my motivation, and this is both the automatic motivation and the reflective motivation that I can have. So things associated with beliefs, with habits, with values, with goals, and opportunity. So social opportunity in terms of social support that I have and the context I'm in, and of course, physical opportunity. Do we have access to what we need in terms of changing behavior? And it was really interesting to see recently in this COVID situation, when talking about influencing behavior such as wearing face masks and washing hands and keeping physical distance, we have seen a lot of research and advice being given to different governments about strategies to change those behaviors that are based on the COMBI model and thinking about these elements of opportunity. For example, if you want to wash your hands frequently, we need to have access to hand sanitizer or to a place where we have water and soap to wash our hands. So all of these elements are fundamental in a lot of different behaviors and have been used to inform stakeholders. So once we identify, is it motivation? Is it capability? Is it opportunity? Is it the three of them that are necessary when we're talking about interventions for self-care and to change health behaviors? Then we can move to identifying what are the key behavior change techniques or content of our intervention that we need to select and implement. And to support stakeholders, both from research and in the practitioner side, with identifying these techniques and implementing them, different groups have been developing what we call taxonomies, so classifications of behavior change techniques that in a way are similar to the periodic table of chemistry and other elements. And the idea is to have methods that are standardized, agreed methods that describe the content of the intervention with consistent terminology and clear labels, so that when we report what we are doing, we can describe our interventions, our counseling, our work as accurately as possible. So if we think about the making every content counts, when describing what is done in those sessions, if we describe the content of those sessions using this language, any researcher or practitioner looking at the description of making every content counts and thinking about implementing in their own country or region can go to these taxonomies and see, okay, this is what they have done. These are the kind of techniques that were implemented. And if we have research looking at the effect of those programs, we can then start to identify which techniques were related with the effects and the positive effects of those interventions. So taxonomies of techniques and help describe interventions accurately, can also help in evaluation what works best. So using different types of dynamic designs that allow us to compare goal setting with planning, for example, and see what is more effective. It's also useful in terms of synthesizing evidence in systematic review. So we can use this in research to identify which techniques were responsible for positive effects of interventions. And of course, in designing interventions, and that's what we were describing as an example. The behavior change techniques taxonomy version 1 is probably the one that has been mostly used around the world. And it was developed by international experts through expert consensus procedures. And it is organized in a hierarchical format, so it improves the way that is, improves ease of use by researchers and practitioners. And it can be applied to any kind of behavior change interventions outside the health care world, although we are, most of our research at the moment has been in implementing in healthcare. Just to give you an example, the way that it is described at the moment, it has 93 techniques that are categorized in 16 groupings, just to help in understanding what is there. And it is described in terms of label, definition, and then examples. And we have this in paper format through peer review papers and through the behavior change wheel books and other support books, but there's also an app and a website describing this. And a lot of different researchers that have been using this in their own research have been adding examples of how these PCTs, behavior change techniques, apply in their research and programs. So the V1 that you can see here on the left side is the one that I've just described, but there are other taxonomies of techniques that are more specific. For example, there is a taxonomy of techniques just for motivation. And more recently, I've been involved in a project with colleagues from University of Helsinki to develop a taxonomy of techniques that can be self-enactable, which I think it's really important in this context as we're talking about self-management of chronic diseases. And the idea of this taxonomy that has more than 100 techniques is to describe the techniques that could be implemented by the individuals themselves without any help from practitioners when using more self-management approaches. So another important aspect that a lot of people ask is, how do we select this behavior change technique? So we have lists with hundreds of techniques. How do we know what to use? Fortunately, we have a lot of meta-analysis and reviews out there at the moment that provide evidence base for which techniques can work. And for example, the competencies framework in the Train for Health project looks at behavior change techniques that are based on this evidence base. We can use the guidance from the behavior change wheel frameworks and other frameworks that already include which techniques are more useful for which behaviors and determinants. And if we are using a more formal theoretical approach, those theoretical approaches sometimes already include guidance on which techniques to use depending on the model. Just as 30 seconds just to say that looking at the content of the interventions is just one aspect in behavioral science that we have been developing taxonomies to describe them, but there are all of these other components related with the mechanisms of actions or determinants, the modes of delivery, reach, engagement, population, behaviors. And there is an ongoing project that I'm part of called the Human Behavior Change Human Behavior Change Project that is developing this ontology of behavior change interventions, describing each component of interventions using a similar approach to what has been done to behavior change techniques. And if you are interested, here are the references. And this project will allow running meta-analysis and systematic reviews in a more automated way to identify which of these components are more effective for our questions. So that's it from my side. Thank you.
Thank you very much, Marta, for your really interesting presentation. And now I open the floor for questions and or considerations to our speaker. As I said before, you can use the chat or just raise your hand in the participant list. Also, you can use our, as my colleague Carlos is writing in the chat, you can use our social media and the website for sharing with us all your suggestions, recommendations, or concerns. So any questions to our speaker, to Marta? Yes? Mara?
Yes, thank you, Beatrice. And thank you so much, Marta, for such a brilliant insight on behavior change science in such a short time. In terms of training, and this is the approach that the Train for Health project takes, in terms of training, you just describe how you should conceptualize things and you focus BCTs. And as you said, we have currently a wide range of BCTs, so 93. And even if you narrow that down into, let's say, 20-ish, as we did in the Train for Health project with your help, it's still a considerable challenge to train students, because you need, first of all, to change a paradigm, and then you need to train students using the BCT. So I was wondering if you have any advice, or what would you recommend to, to streamline this process?
Yeah. Well, first of all, it is a bit challenging and demanding. I think that following a bit from what Maria was saying in her presentation and talking about the training, I think this is a process where the behavioral change training aspect needs to be present when training students to start with. Instead of jumping immediately, these are the kind of techniques that you can use in a given intervention. I think the first thing is that students need to understand why it is important to talk about behavior change techniques and use behavior change techniques and the entire process. So it is integrating this in the curriculum and the way that we provide training. I think the other aspect is that a lot of the behavior change techniques that we use are already used by healthcare professionals in their work. And they're already part of giving counseling. I think most healthcare professionals will provide advice on how to change behavior and instructions on how to perform behaviors, and probably talk about goal setting. But it's not systematized on using a language and using examples and providing it in a way that we know that is more effective. So I think a way to do this is to start from what is the knowledge that already exists in students' training about education and changing behaviors, and then try to improve this language in the BCT world or the behavioral science world with a clear explanation of when should they be implemented. So how should they be implemented and when to be more effective? Because I think one of the issues is that although healthcare professionals can use goal setting, sometimes they will use goal setting in the wrong way, in the wrong situation, and without using other techniques before that need to be used, or without considering what is the problem there. If the problem is lack of social support, doing goal setting is probably not the most effective behavior change technique. We need to implement others. So I think it is integrating what is already being implemented and in the curriculum and in the training for students, and use this language and this systematized approach to help selecting the more effective and implementing in the more effective way. And just to say, although there are 93 techniques, as you mentioned, there is a core group of techniques that we can start with. And I think that once they are embedded in the programs and in the guidelines, it becomes much more easier to be used and becomes part of your regular process when developing counseling.
Great. Thank you, Marta, for your answer. Yeah. Any other question? I don't see any hand, and I don't see any other question. Maybe after the three speech, we will have more questions for you, Marta. Okay, well, thank you so much. And now let's move on to our last speaker, Dr. Catherine Duggan. She's the Chief Executive Officer of the International Pharmaceutical Federation. So, Catherine, the floor is yours. You can share with us your screen, please.
Morning, everybody. How is everybody today? I hope I find everybody well. I'm just sharing the screen right now, and I hope you can see it.
Yes, perfectly.
Doing well? Perfect. Excellent. So lovely to be part of today's virtual conference. And as we said before we started, it's really delightful to spend the morning with all of you. And I see some familiar names on the screen. So hello to old friends and hello to new colleagues. Thanks so much to Maria and Marta for setting the scene. I'm going to take a similar approach. I'm going to skip us along quite rapidly through several different ways in which pharmacy can contribute to self-care support and chronic disease management globally. And of course, there's lots of detail that people can follow up with FIP thereafter. But it's really just to give us an overview today. And we'll use the time to best effect. Okay, so a little bit about FIP then. We were founded in 1912. We're a non-governmental organisation. We've been in official relationships with the World Health Organization since its inception in 1948. We have more than 150 member organisations in 104 countries and territories, so about 60% globally. We have more than 30 observer organisations and more than 170 academic institutional members. In all, we represent about 4 million pharmacists, pharmaceutical scientists, and pharmaceutical educators. Vision for FIP is a world where everyone benefits from access to safe and effective medicines and pharmaceutical care. And really, when we think about the presentations today, this encompasses everything that pharmacy can do to ensure that we have good self-care for those who are managing chronic diseases. Our mission is to play our part in pharmacy to improve global health by supporting the advancement of our practice, our sciences, and our education. But one of the things that I'm going to build on, and I think it's been really well worked through by both Maria and Marta, is that you can't do things on your own. So FIP truly believes that you work better if you work shoulder to shoulder with other organisations. So we've been working with WHO since 1948, but last year we signed the first MOU between ourselves to really focus on workforce, patient safety, primary healthcare, and I'll walk you through some of those things. But really, big theme is whether we're working with our patients, whether we're working with our communities, whether we're working with other professions, we really have to work in collaboration. And I'm not being political, but during COVID-19, you can see organisations and nations who do this have done better in managing emergencies and crises, and organisations and governments who don't work in collaboration have done less well. So for today, the focus is on advancing self-care support and what has pharmacy done? And it's really difficult, isn't it, for us to consider how we might manage transformation. It's very complex. I think Marta just explained how complex it is to think through managing the 93 models in a patient-based exchange. And we've got to think globally, nationally, locally, individually, and then how do you make a strategy deliverable in practice? So I'm going to walk you through some examples of how pharmacy has done this at a global level, but also more specifically, how we can all do this in the profession. So we start really with a bit of a imperative for change. We know things have gone well in terms of global health in the last 100 years. We also know we have a lot of problems still yet to overcome. Despite the fact that our average age globally, mortality-wise, is 71, we have almost 6 million children each year dying under the age of 5 years. And it's very interesting to see why these children die, and it tends to be in areas where there is conflict or areas where there is a vulnerable health system, or down to things that we're all experiencing at the moment, like local epidemics. And we also see there's a need really for us all to look at how we manage the costs of healthcare and how we support our societies to become more empowered with their own self-care. If you take it back all the way, nearly a decade ago, we're really starting to think about how much spend you can avoid in the health system by managing our medicines responsibly. And I think that's really the crux of how pharmacy can play a central role in supporting patients who have chronic conditions, chronic diseases, comorbidities, with their appropriate and responsible medicines management alongside all issues of self-care. We held a health ministers report summit in 2012 at the FIP Centennial, and there we published the reports that you see here, following up with the chief pharmacist meeting in Dublin in 2013. And the issue here is that you put out a policy and a report, but when you have health ministers in a room with you, you want to demonstrate some concrete outcomes and concrete actions. And we have some plans afoot to follow up with a health ministers summit in Cape Town in 2023, which will make a nice decade full circle. Now, these two reports really give us an idea of global pharmacy. What does pharmacy do? Where is our workforce distributed? What about medicines distributions itself? What about practice, regulation and remuneration? And this was published in 2016. We will have an update of this next year. Really what we can say from this is that the age of industrial medicine has become information age healthcare by 2016. And I think, you know, colleagues, we're all on a digital conference today. We know that 2020 has led us to make a decade leap, or maybe even more, in terms of information age, digital age delivery. Patients and consumers with greater education, knowledge and power need and want pharmacists and pharmacy services to optimise their medication therapy outcomes, with an emphasis on self-care. So when we look at how many pharmacists there are, we see that there's a big variation. The median density of pharmacists per 10,000 population in the study is about 5. However, the figure for high-income countries and territories rises to 7.6, and that's nearly 13 times higher than for low-income countries, which is about 0.6. Now, we're not saying that anywhere has got the numbers right, but what we're seeing is a variation in numbers, need and delivery. And it may well be, over time, we need to work out how many pharmacists do you need per 10,000 population to get a good standard of pharmaceutical care in your communities. We also see that 75% of actively practicing pharmacists work in community globally, and your countries will all have different proportions, but broadly speaking, it's about 70 to 75%. About 13% of us work in hospital pharmacy and 12% in other areas. And then when you think about the different WHO regions, we see community pharmacy represents at least 2/3 of practicing pharmacists, except in Africa and the Eastern Mediterranean regions, where they represent slightly less than 40% of pharmacists. Now, colleagues, when we look at how essential community pharmacy has been in recent months, providing access to essential medicines during the COVID-19 pandemic everywhere, providing expertise and absolutely free from appointments, opening to offer advice to communities. We know that you need pharmacies and we know you need pharmacists. And if we find in the poorer areas of the world, like the African regions and EMRO, that we have a less proportion, this is something that we need to address globally. Again, there's variations. I'm not dictating what a good number is, but I'm just saying it's worth us thinking through. Now, colleagues, when I started in 2018, I was lucky enough to attend the Astana Congress, which was in Kazakhstan in the October of that year. And that was where the declaration, the 40-year declaration on primary healthcare was renewed and reinforced. And we were able to demonstrate and support that pharmacy is aligned with the primary healthcare agenda. So FIP needs to have a primary healthcare strategy. And when we talk about primary healthcare, we're not talking about primary care, where we see GPs working. We're talking about primary healthcare with a focus on prevention, long-term condition management, self-care, and management of acute exacerbation. Every single patient-facing pharmacist has a role to play in this, and there is no primary healthcare without pharmacy in all sectors. And the 3 bubbles of activity we were focusing on at this time were around non-communicable diseases, prevention agenda, from self-care all the way through to vaccination and immunisation, and the safety agenda. Again, working in collaboration, in solidarity, and in partnership. Thinking about today, the fact that this is about self-care, self-actualization, empowerment, I thought it useful to put up a slide that many of you will know from many years, that the self-care continuum is fluid, and we find ourselves on different points of the scale at different points in our lives. And we can see that with family, we can see that with relatives, we can see that with people who've been struck down with COVID, and especially the interaction of COVID-19 with existing comorbidities and non-communicable diseases. From pure secure medical care in parentheses on the right. And the management of all of these conditions, pharmacy has a role in. I just wanted to walk you through non-communicable diseases, also known as chronic diseases. These tend to be of a long duration. They're a result of combination of genetic, physiological, environmental and behavioural factors. We know NCDs will account for about 80% of the global burden of disease, that 7 out of every 10 deaths in developing countries are associated with non-communicable diseases. This might seem like almost like a fate, but actually we can do something about this. This isn't about living longer, it's about living well for longer, and we need to support our patients with their non-communicable diseases to live long and healthy lives. We know the WHO tells us that more than 36 million people die annually from NCDs. This represents about 60% of deaths worldwide. That's quite a sobering point, 15 million of which occur before the age of 70. It represents a major challenge for health systems, and prevention and control of NCDs require interventions that need to be effective, cost-effective, affordable and feasible. And they need to be nationally appropriate, but also the coverage needs to be aligned with global policy. And WHO defined 4 priorities to tackle NCDs around cardiovascular disease, diabetes, asthma and cancer. And pharmacists need, require and must have a role. And I'll walk you through some of those interventions. Pharmacists are relevant and valuable as a health resource in the fight against NCDs, including the prevention agenda and self-care. We know that pharmacists represent access as the most frequently visited health professional, and really about promoting the access to expert advice alongside medicines themselves is something that we as an organisation need to articulate very clearly to our health ministers. Pharmacists are able to perform many activities in the healthcare team, and we know that there's a bit of territory around this, that very often we see doctors in some countries becoming a bit threatened when pharmacists move into roles that might have been traditionally more medical. But all I can say to you is the evidence shows us there's enough disease and enough illness to go around for all the health professions to have a role. And when you think about the impact that pharmacists can have in addition to the impact that medical colleagues and nursing colleagues can have, we really can start to make a seismic change. This slide really just describes how we can provide services and triage to colleagues and patients at different points in the disease cycle. Now, of course, we don't describe healthy subjects routinely as patients, but it's worth noting that if we're really active in this group, we keep them as long as possible as healthy subjects. We have some reports that can help with this if anybody would like to investigate more. We published this last year on World Health Day, and we've had it translated into 7 languages so far. And then I just wanted to show you that community pharmacy involvement in NCD prevention is highly variable again, but you can see that cardiovascular disease pharmacy plays an active role continuously. One of the reasons why cancer is lower down on that scale is purely because a lot of cancer treatment takes place in specialised areas. So the community pharmacist access may not be quite as involved in self-care. However, that's an opportunity for the profession. You also see from here cardiovascular involvement of community pharmacists. We know from the FIP member organisations, this is the area where there's most activity, and this is from our NCD report from last year. I also wanted to show, I think this fits very much with Marta's presentation and what Maria was saying about embedding these behaviours early in the career. I do apologise for the formatting on one of those bubbles, but really there's a lot that we can do around physical activity campaigns. Nutrition, for example, healthy eating counselling can impact on more than one at each time of these NCDs. In addition, there's some preventative impacts we can have, including establishing tobacco-free communities. A practical guide for pharmacists has been published, and actually you can see this has a really big impact politically 5 years ago. Now it's viewed very much as business as usual. So the things that we can do around prevention agenda become normal over time. We also see the impact of community pharmacists in screening patients for various non-communicable diseases. For example, pharmacist-led screening programs. Oh, apologies, colleague. Somebody is not on mute.
Yes, please. The participants can mute the microphone. Yes. Sorry, Catherine, you can continue.
No problem at all. We see pharmacist-led screening programs such as blood glucose, cholesterol screening, target high-risk individuals through symptom assessment and point-of-care measurements. And the impact of this is startling. I think this also shows you where the community pharmacist may observe people who come into the pharmacy regularly and offer some of these screening programs as opportunistic opportunities. We also see several point-of-care tests for screening potential diabetic patients in the community. These include blood glucose, glycated hemoglobin A1C, the Findrick test, total blood cholesterol, HDL cholesterol, triglycerides, LDL cholesterol. You know, building on what Marta mentioned, you need to be able to use the most appropriate tests at the most appropriate time, and building a complete picture of the way in which a patient is either to be diagnosed or managing their disease with multiple tests is obviously very useful. Basically, it provides us with a better understanding of the patient's status. Now, I mentioned about collaboration earlier on. We issued a joint statement with the World Self-Care Medication Organization last year. It's very important that we work in collaboration with other organizations who may well be involved in providing medicines to community pharmacies or the over-the-counter agenda. And again, that theme of working in collaboration, in solidarity, in partnership is key here. It's really important that FIP supports our community colleagues with the best available information. And it was interesting, we published this last year. Actually, it was very timely because our community colleagues have needed to really be promoting responsible self-medication this year during the COVID pandemic. But this was 20 years since we'd done a joint statement. So it was really, really timely. The WSMI has now been rebranded as the Global Self-Care Federation, for everybody to note. So the WSMI doesn't exist anymore, it's the GSCF. Now, just bringing you on finally to a theme around the workforce and what we do for the workforce to make sure that we have appropriate pharmacy services in our different countries based on their needs. We need the appropriate workforce to be deployed. Now, we know that WHO estimate that there is a need for 40 million new jobs by 2030. So what we need to do is fourfold. We need to optimize our existing workforce. We need to anticipate and align investment in our future workforces, which also includes looking at gender profiling of the workforce and the age of our workforce. We need to strengthen policy planning and implementation, and we need to look at gaps. And I mentioned to you earlier on that of particular need is EMRO and AFRO WHO regions around community pharmacy services. So what can FIP do to support primary healthcare in those countries by making sure we have an increased workforce? There is no healthcare transformation without a transformative workforce. And in pharmacy, we wanted to make sure that we would have the right goals in place. So in 2016, FIP published the 13 pharmaceutical workforce development goals. These align very closely to the global strategy I just mentioned and really set in train some action points for delivery of those goals over the subsequent years. We also made sure that anything that was coming out from the high-level commission on health, employment and economic growth mentioned pharmacy, or that we responded to it, to make sure that pharmacy is part of the solution for primary healthcare and universal health coverage. And working at the World Health Assembly 2 years ago, that's when I just started in post. That was my first how would I say, my first mission was to attend that World Health Assembly, where in the 5-year action plan, pharmacy is clearly articulated. And then I mentioned to colleagues that we attended the Astana Congress in October that year, where we ensured that pharmacy was embedded in every element of primary healthcare. And each of those pharmaceutical goals has a definition and a plan, and the overlaps are identified. Since then, we've set up a workforce development hub, and I know I have some colleagues on the call today who are part of that leadership role in the workforce development hub for FIP. And those projects are embedded under each goal and being delivered over the next 1, 3, 5 years. Again, working in collaboration, in solidarity, in partnership. If pharmacy tries to do these things on our own, we will be much less successful. It's really important that we align closely with global health workforce strategies, and then the pharmacy workforce strategy is evident. So we know, oh, I apologise. Colleagues, could you mute your microphones, please? I promise I'm nearly there. What we needed for the workforce development goals was a global vision so that we could set the direction and the progress, and then we could set the tools that would support the workforce development through advanced development frameworks and competency frameworks. And this really lines up with what Maria presented right at the beginning of this morning, with the frameworks we need in place to support development. Frameworks aren't constraining, they are all about providing direction and support as we move through our career. To have a framework in place at day 1 as an undergraduate, and then to know that you have support tools on day 1001 and day 2001 is very comforting, I think, for a profession managing different patient needs. This is quite a busy slide, but what it shows you here, colleagues, is from the launch of the Pharmaceutical Workforce Development Goals in Nanjing, in a special conference that FIP held in November of that year, the Global Vision for Education and Workforce was launched. In 2017, the Nanjing Report on Workforce and Education was launched to confirm the commitment to action by FIP to support members across the globe to implement the Pharmaceutical Workforce Development Goals. Not top down, but a little bit like how Maria was talking about. You get the countries themselves and the member organisations themselves to identify their needs and their priorities, and then FIP is in a position to support them. And you never know, you can even get members who have needs matched up with members who have skills, and it forms a perfect triangle of alliance and collaboration. In 2018, we set up the Workforce Development Hub that I mentioned to develop evidence and tools and frameworks to support everyone to deliver the Pharmaceutical Workforce Development Goals. In 2019, we set up the first workforce transformation programs with Indonesia and with Jordan, and you see a picture there of myself and President Jordan signing a memorandum of understanding with the President and CEO of the Jordanian Pharmacy Association, and really implementing their transformation program. Once a minister understands that pharmacy is a solution to primary healthcare and universal health coverage, we see the lights are lit and there's an opportunity there to embed. And this year at our Global Congress, we will be launching the FIP development goals, which now take those workforce development goals and add on some goals for the next decade around practice and science. You'll see these include things like medicines expertise, policy development, access to medicines and services, antimicrobial stewardship, sustainable pharmacy, pharmaceuticals, and patient safety. You see all of these areas here now will be launched to set out a roadmap for the next 10 years aligned with the Sustainable Development Goals from the United Nations. As I started at the beginning, it's really important that pharmacy is aligned with primary healthcare. There is no primary healthcare without prevention, long-term condition management, self-care, and then management of acute exacerbations. So we would argue at FIP, there's no primary healthcare without pharmacy in all sectors. There's our 3 bubbles, and we can't do it alone. We have to do it in collaboration, in solidarity, and in partnership. I thank you for your attention. Thanks for the invitation, and thank you for the opportunity.
Thank you very much, Catherine, for this absolutely amazing presentation. It's really, really, really interesting to learn from you. Now I open the floor For questions, you can use the chat, and also you can raise a hand in the participant list. So, Mara, please.
Right, thank you, Beatrice. I don't want to monopolize the questions and answers, but I might as well just start and hopefully others will follow. First of all, thank you so much, Catherine, for giving a good insight on what pharmacists do, because well, just like you and just like FIP, I'm very much an advocate for collaboration, for working in solidarity and for working in partnership, but you can't really do that unless you understand what others do. So that's a very important first step, I would say. So thank you for briefing. We have an interprofessional audience here, so thank you for briefing colleagues from different areas on what a pharmacist does in the community. Now, my question is, you in FIP, you have quite a robust background, I would say, in terms of competency frameworks, and you actually have a global competency framework for pharmacy. In the Train for Health project, we are developing a competency framework for behavior change support in chronic diseases, and Martha explained that's part of the behavioral science approach. Now, my question is, when you start thinking of competency frameworks, you have the global ones or the generic ones for a profession, you have the interprofessional ones, you have some competency frameworks that will only cover one aspect as ours. And my question is, how do you make sense of so many competency frameworks? How do you link them? How do you make that, so how do you make them work in collaboration, in partnership?
A very good point, Mara. In my previous role in Great Britain, we found that we had maybe 27 different competency frameworks, you know, for cancer, for emergency care, for primary care, for XYZ. And in pharmacy, in particular, we love to have our disciplines and our specialties labelled and boxed off. What we actually found when we did a study on this to see what was common was 85% of the knowledge and skills that you need to be able to manage advanced generalism was covered by all of them. And then what we saw were a little additional pieces of competencies that you might need for different environments and different patient cases. So I would suggest that what we need to do is be intensely relaxed about understanding that a lot of what will be in each of those competency frameworks you would have already, especially at a certain stage in your career. And then you're looking for the pieces of the jigsaw that you need to upskill. Mara, I would say we're in a real risk in our profession if each time we move from position or patient group, we have to come down our mountain of development and do it all again, rather than jumping from mountain to mountain and just upskilling in the bit that is the specialist bit. And I need some pictures, I need to be able to draw this for you, but identifying what is common for the profession, what is common between the professions is really important. And I also think that would take away a lot of tension about who's doing which job that might look traditionally like someone else's job, because I don't think that's the case. That's not what I'm advocating for. I think each profession has a very unique set of contributions to patient care, and this would be a very useful exercise.
Okay, thank you for your answer. We have another question from Maria Sierra from ESU. She says, thank you for your great intervention. I would like to congratulate FIP for building such great international collaboration. Just wondering if those global workforce strategies have an impact in a more local or national level. And also collaboration is key, as you said, but how to build sustainable collaboration?
The collaboration piece. So if you think about developing a collaboration, what a great question. So let me start with, you have to start by creating a relationship of trust. And if you have a relationship of trust, or you have shared values, and maybe you have to write that down between yourselves, but then you work out a joint venture that has a very low risk but a very high chance of success, I think the buzzwords are win-win. Then you understand how each other works. If you take that from an organizational perspective, it's exactly the same. You start with a conversation. You start with, what are your needs and what are your problems? What are your needs and what are your problems? Can we do something together? Is there something very quick we can work on just to establish some trust and some success? Because success drives collaboration. And sometimes you just have to do it. And if you have something in place for 1 year and you don't have, you have a friendly relationship with each other, then if it isn't working, you can walk away and maybe renew it in a couple of years' time. Now, the other thing that Maria was asking was, what about global to regional to local? So I mentioned we went to the Astana event in 2018, and from that came the idea that pharmacy has a role to play in primary healthcare. Do you know, it's a win-win, because pharmacy's been doing this for years. Most of this is about telling our health ministries in each country what we do with evidence. So we started a program of regional conferences, and last year we did one in Emro in Jordan with all of the Eastern Mediterranean countries where we have member organizations and where we don't, invited. And then we had one in Ankara for the European region. And at the end of each of those conferences, we had a commitment to primary healthcare signed up by all of those member organizations. And then we plan to follow up with each of those member organizations to see how FIP can help, but also how other colleagues in that region can help. And for example, in the European conference last October in Ankara, we had so many colleagues who would come from Serbia and from Poland and from Czech Republic, who then saw what Turkey had done and they were the same kinds of needs that they had, so they wanted to partner up with Turkey. So the idea here is that we create alliances and platforms for countries in a region to work together, maybe even countries across regions as well, because we see lots of similar health needs across the regions. And FIP is here to support, but we're not here to dictate or to say, you must do it like that. One other thing that we've been doing very quickly was to be able to support countries, member organizations in countries where they needed some advocacy at their health ministry. And do you all understand the phrase, you cannot be a prophet in your own country? It's often very good to have somebody from somewhere else come in and tell the politicians how good pharmacy is from their perspective, rather than in your own country you have to battle. This is very true. So some nice tactics about how we can support people. There's a third thing that we can do. I showed you some of those big reports which outline what happens in your country, how many pharmacists you have, how many pharmacy team members you have, what do you do, what do you deliver. Our big global surveys now really will provide us with data, and much more responsive data on an annual basis for what is the need of your country, what workforce do you have, what are the solutions, how can we help you. So that's another way that we can do that, and that's through our Global Pharmaceutical Observatory and our member surveys. We're just about to launch a great big survey in August, and it's taken us a few months because we found there were about 40 different surveys going on in FIP, so we wanted to gather them together, so not everybody got 40 surveys in the year. I'm not sure about you, but I would be exhausted answering 40. So if it's one big one with a couple of extra ones, that feels better to me. So lots of ways we can support national and then local, but we would never do that in a country where we have a member organisation directly to those pharmacists. We always work with and through our member organisations, which is really important. Long answer.
But amazing answer. Thank you so much. We have another question, so now we open the floor for questions to our three speakers. We have a question from Isa Felix from ESEL, our project coordinator. She says, thank you, Maria, Marta, and Catherine for your great interventions. My question is for Marta Marquez. How can we combine BCT and modes of delivery, when we are training students? Is there any evidence which modes of delivery are more effective according to the BCT used? Marta?
Yep, thank you, Isa. Well, So first, there isn't enough evidence to support that. It is, I think it's one of the key research aims at the moment. So we have just published an ontology describing modes of delivery at the moment. And there's been some ongoing research, especially more in digital, in the digital world, trying to link behavior change techniques with the way they are delivered. And just to clarify, by modes of delivery, we mean face-to-face, distance, telephone, using newsletters, using apps, email, whatever we do in interactions. And even if it is face-to-face, sometimes we have paper-based things that we provide to patients and all of that. What would be really important is that we can identify, for example, going back to goal setting, is goal setting more effective on a talking interaction base? Is it more effective if we have it written down? Is it more effective on a digital component or paper? Unfortunately, we don't have enough evidence. So I think that the training at the moment is a bit more broad in terms of these are the modes of delivery that exist, and for your specific area that you're intervening and the behavior you are promoting, what we know from previous programs, and if they were effective in previous programs, trying to use that. But in terms of training, it has to be more broad at the moment, and it's more providing this awareness to students that the way that the BCTs are delivered can have different effects. And knowing that will give you more conscious on when you choose what you're doing, and in reporting what you're doing, how we will describe those modes of delivery. And hopefully, if we start describing that, I hope that in a few years, we will know which modes of delivery are more effective.
Okay, thank you, Marta. We have another question from Mara. Marta, at an undergraduate level, many students are trained in the motivational interviews. What bridges can be built with the BCW?
Yes. So one thing of the behavior change wheel framework and this frameworks to develop interventions is that they are quite flexible in the way they operate. So there is this guidance on the steps and how to select things, but when it comes to the content of your intervention, there are different techniques that you can implement. The way we see motivational interviewing at the moment is a method of providing behavior change, focusing more on the motivational aspects. So motivational interviewing method or techniques would fit on the step of the content. So where you have the BCTs, you can also have motivational interviewing techniques. And actually, there is a taxonomy describing the motivational interviewing techniques that you can use by a colleague called Sarah Hardcastle that describes all of those techniques that you can implement. So the motivational interviewing would be part of that step where we select which methods, which techniques, but with an important element is that if in the behavior change wheel, we look at the source of the behaviors in the green layer. So we would only use motivational interviewing techniques if we would identify that motivation is an element that is responsible for that specific behavior change.
Okay, thank you, Marta, for your answer. Any other question? I don't see any hand and no any question. Okay, thank you. Now I give the floor to Mara for the wrap-up session. So Mara, please. And also I saw your, I see your hand now. Yeah, sorry.
No, I just
It's a double, it's a hand, so it's a question from you, and then after that, the wrap-up.
Okay, can I make my question then?
Yes, please.
Yeah. Okay, thank you. It's for Catherine actually, and Catherine has a lot of experience in building bridges with other professions, and that's something quite important when we are working interprofessionally, because as Catherine said, unless you have trust, you can't really work it out. So you can't really work with other professions. So Catherine, you gave us a few hints on how we can successfully work with allied professions. Could you give us perhaps a last piece of advice?
So my piece of advice would be, you've got to look at the bigger picture. This is decades of experience where things have gone well, but also where things don't go so well. So I would suggest, Mara, the top tips are identify the win-win, and don't chase the difficult areas to begin with. Chase the areas where you can see there will be success. So if it's pharmacists working with nurses and dentists and doctors and physical therapists and midwives, we look for something in the middle where we can all contribute and we can all have a success. And once you do that, you build the trust. The key thing there is don't sweat the small stuff. And it really it really helps us then to establish those relationships and those collaboration. In pharmacy, we are very perfectionist, and we will always say, oh, this was really good, but some little things went wrong. And, you know, don't focus on those little things. We have to change our professional cultural paradigm and look at the success, and the other pieces that haven't gone so well, they're for next time. They are our learnings. And this has really, really helped me. I don't always get this right. Don't get me wrong. It's not, you know, this isn't easy, but it's a good blueprint to start from. And I think that works very well locally. If you are a pharmacist working in your pharmacy or working in a hospital and you have to collaborate with doctors and nurses nearby, this is a way to do it. But if you're a chief executive and you work with the doctors and the dentists and the nurses and the physical therapists, that it still works this way. You have to step into the shared territory and make a success. And then you can learn where things go well, tick. And then for next time, where things don't go so well. Don't beat yourself up.
Thank you so much, Catherine, for this precious tip. Right, so I have the job of wrapping up. So first of all, thanking our guest speakers and everyone who joined us here today. Well, July is not a great month for webinars, but I think we just proved that we can make a successful webinar in July, so that is good. It was brilliant to hear the talks of our guest speakers and the debate and the questions and answers. I think we in the Train for Health project have a lot of food for thought. So let me tell you what will follow. So you will receive a certificate of attendance provided that your name in a Zoom session is readable and can be verified. Then, with the consent of our speakers, we are going to make the slides available as PDFs in the project website. And as you might have noticed, the session was recorded, again with the consent of our speakers, and so the recording will equally be made available in the Train for Health website. I noticed that Carlos was posting in a chat some links to the website and social media, so for those interested, you can follow us. Just a last note, this was the second webinar of our first webinar series, so it means for those that are interested in self-care, in chronic diseases and behavior change support education in this area, we're going to resume the webinars in September, so stay tuned. Thank you so much.
Okay.
Thank you.
Thank you, Mara. So just a final word from my side. Maria, Marta, and Catherine, really, really thank you for your amazing speech, for your amazing presentation. Really interesting for all of us, and especially for the Train for Health activities. So really, thank you. So useful for us. Thank you so much for attending to our project partners, Train for Health project partners. Thank you for being here. And for sure, especially thank you for the rest of participants for attending in July in this concrete webinar focused on chronic disease. So really thank you. We really hope that you will enjoy this webinar and you will learn a lot from our speakers and from our project. And just as a final word, please visit our website, share our social media, and if you need any kind of further information or clarification from our side, you want to know more about the project, do you want to learn more about us and about our activities, please contact us through our website or social media, and it would be absolutely a pleasure for us to share the information with all of you.